Good afternoon, everyone, and welcome to today's Lunch and Learn webinar for the Iowa Pediatric Mental Health Collaborative, Preschool ADHD Part 1, presented by Dr. Burgundy Johnson. My name is Coffee Dixon, and I'll be moderating the session today. I'll cover a few housekeeping announcements before we get started. The webinar will be recorded and made available for viewing on our YouTube channel. The link will be shared in the follow-up email after the session. Following the presentation, we'll have time for questions. Please use the Q&A feature in the webinar toolbar to submit your questions, and we'll cover as many as we can in the time allowed. For this two-part webinar, you'll claim continuing education credit for each session separately. So I'll add the instructions for how to claim credit in the chat, and I'll also send this in the follow-up email after the session. So without further delay, it's my pleasure to introduce our guest speaker, Dr. Burgundy Johnson. Dr. Johnson is currently the Division Lead of Child and Adolescent Psychiatry at Carle BroMenn Medical Center, as well as Adjunct Clinical Assistant Professor in Child Psychiatry at the University of Iowa Hospitals and Clinics. She did her Child Psychiatry Fellowship and General Psychiatry Residency at the University of Iowa Hospitals and Clinics. Her interests are community psychiatry, therapeutic approaches, and early childhood mental health. She lives in Iowa City with her husband, 2 sons, and 2 cats. So thank you, Dr. Johnson, and I'll turn it over to you.
Awesome. Thank you. Can you guys hear me okay? Coffee? Okay, cool.
Yes, perfect.
Great. So we are going to be flying through some information today. People who've seen me talk before know that I talk too fast and have too much information. And today will not disappoint. We're going to follow with that. This is a topic I really like. So probably I have too many slides and each one could be its own discussion. One thing that I want to say is that I will have slides that I skip over. You'll see that. It's not because there's anything wrong. I just wanted to leave things in there in case there were questions in the future or people wanted that information when looking back at the slides. So theoretically, you should just listen. But if you're more of someone who likes to read, you can also read the slides. Anyway, let's get into it. So like Coffee said, I'm Burgundy Johnson. I'm a child psychiatrist. I do not have any disclosures. Today, we're basically going to be learning about the basics of preschool ADHD. Now, let's start with just some basic numbers. So 10% of kids in the US have ADHD. That's what the estimate is. It has been that number for quite a while now. Actually, the last couple of times we've done surveys, we've gotten that same percentage. Now, most kids, when they're diagnosed with ADHD, it's 6 and later. So the majority of kids are not diagnosed prior to 6. We're going to be talking about those outliers today that are not within the norm. And it makes sense because when you look at the bell curves, when you look at the curves of how the symptoms generally present, usually, I have it down here on the bottom, but usually we do see ADHD symptoms prior to the age of 4 for all kids who end up having ADHD. When parents look back, they usually see it prior to 4, but it doesn't peak until a couple of years later. So it makes sense if we have that peak at age 7 or 8 of impulsivity and hyperactivity, then it makes sense that we're not diagnosing until later. So this talk, I don't want you to think, oh, everyone's missing preschool ADHD. They're not. It is the outlier. So those of you who make it after age 6, you're doing the right thing, more than likely, just to put that out there. Inattentive ADHD is a little bit different. It presents later, but we won't be talking about that too much today. So I put in here, we're filling in the gaps. A lot of the stuff assumes that you know about sort of basic ADHD stuff, and I'm going to be adding on top of that information. So what actually is preschool ADHD, right? In the literature, sometimes it's also called early onset ADHD. It is not its own necessarily like group or category. You know, in the DSM, all ADHD is just all ADHD. All the same criteria applies to everyone. So this doesn't come with its own criteria. What makes this different is that in the studies, they've shown that this group of kids who have significant enough ADHD symptoms to be called ADHD in the preschool period between 3 and 5, or at least under 6, those kids benefit from diagnosis and treatment early on. So the way I look at it is in most kids with any condition, usually whether it's psychiatric or not, we kind of just wait and watch. And this is true here, except there's always going to be a subset of a population where it's more important to diagnose and treat earlier because of severity and potential issues. And this is no exception. So we had this big study that we did in psychiatry that was really good, the PAT study, technically the Preschool ADHD study. And that's what a lot of this information is based on. It looked at kids who have ADHD and followed them over years. So we started in early on preschool and we followed them over years. And they found, and I'll get into the preschool study a little bit more later, but they found that these kids, 3 to 6 basically, who met criteria for severe symptoms of ADHD in the preschool period, they're almost all going to go on to have ADHD. So I know a lot of us are like, probably the main question today is, how do I tell a normal hyperactive kid from a preschool, like from a preschool ADHD? Well, there is criteria for that, and a lot of it comes out of this, and it shows us the ones who have the most severe symptoms, they're going to end up having the diagnosis. So we might as well call it early as opposed to wait. And they're the ones that have more specific treatment guidelines of therapy and medications because we want to try and prevent issues. What kind of things do we want to prevent? Well, lots of bad stuff can happen with ADHD. Not that there aren't strengths with ADHD, but with ADHD comes a much higher risk for morbidity and mortality, accidents, injuries. Not only that, but there are other sequelae that can occur developmentally. So one thing leads to another. A kid who's maybe not doing well in school and has social issues, maybe they fall into the bad crowd. Not that I ever want to call a kid part of a bad crowd, but then, maybe they then get into drugs and then they don't do well and then they drop out. Again, this is all sounds dramatic, but at any point when we treat ADHD, we're trying to prevent some of that stuff. Now, with young kids in the preschool period, they're at higher risk for these things, they've shown. Partially because it's earlier, partially because the earlier you have a problem, the more it affects other parts of life, So a kid who has the peak of ADHD symptoms at 8, they have a lot of stuff under their belt. Whereas someone who peaks at 3 and 4 or, is severe by then, they're already still developing a lot of social basic stuff, a lot of physical, just a lot of basics that can be hindered by having severe symptoms early on. So now that I've explained to you just some of the basics, I want to tell you about 3 cases I've seen. And I've seen many kids with preschool ADHD, partially because it's my interest, but 3 cases where I saw them and I thought, oh, okay, this is a thing, and they should get treatment. The first kid I ever saw, and I think I was like just had started being an attending, was a preschool kid who, I'll save some of the background, but during the visit, this was during COVID, she actually was on the visit, she took her mom's phone and started running through oncoming traffic while on the visit with me. And I don't know a better way, I had a heart attack at that point. She was running through oncoming traffic. I'm watching cars fly by her, trying not to hit her as she's cracking up on the phone. And I'm yelling, go to your mom. Her mom, this was not a supervision issue. Her mom was right behind her screaming, holding a baby, trying to get her to come out. And I thought, I'm going to watch a child die on video today. I don't know what to do. I can't just hang up in the middle of this. She ended up being okay, but that was not the first time she had done things like that. So that I remember thinking, this kid's going to die without a medication. Maybe she won't. Hopefully that would be the case, but I feel pretty okay with calling it and treating it. And that was sort of my first taste of this. And then 2 other cases that I think also are good examples of what we're looking for when we're looking for this severe category in this age group. I had one kid who, I put this picture on here, I'd been monitoring for ADHD, whole family had it, she had some stuff, but I wasn't going to treat it because it wasn't enough to call it. And then she jumped into an empty pool, Superman style, and broke her face. And she's okay. So that sounds dramatic, but she ended up being okay, but she did have multiple broken bones in her face. Again, great mom providing supervision. This was not a supervision issue. This was not a trauma issue. This was pure on impulsivity. A third kid that I saw who made me think yeah, this is a real thing was a kid who his favorite thing to do was to try and play chicken with cars. He liked to run at oncoming cars and see if they would stop in time to not hit him. Now, his parents were they were living on the edge of their seat trying to make sure their child didn't get hit. And, I'm sure they had anxiety disorders appropriately at this point. And at one point, they weren't able to stop him, and a car ran over their child. And he ended up being okay. Again, multiple broken bones, things like that. So I don't want to make it sound like it was nothing, but this child didn't die. But the parents, I remember as they were talking to me, they were like, the crazy thing is that the car just didn't run over our child. Our child ran into the car. This was a kid who thought this was hilarious. So that is the kind of severe impulsivity we see when we're thinking, okay, this kid has ADHD. Yes, of course, there can be more mild cases, but when you're focusing on what to look for and what to treat, start with those cases, because when you see the most severe, you get an idea for what this can look like. Another thing I want to say is that this is a real thing. This is not the Wild West. We're not trying to overdiagnose young kids. There are guidelines, there are studies. Preschool ADHD exists. All the major organizations have guidelines for it. Now, most of the guidelines say that you can diagnose ADHD starting at age 4. Some of them say age 3. You can reliably do it at age 4, but it can exist 3 and above. So that is a possibility. And I do treat some 3-year-olds. Now, one thing we have to talk about that's a little bit different than other kids with ADHD is we have to talk a little bit more about parenting. Yes, it's always a topic with all kids who have ADHD, but especially when they're young, the parenting issue is a bigger part, I guess I will say. And the one thing that I want to stress is these parents are burnt out, partially because by the time they actually get treatment, things like that have been going on for 3 years. So if you can imagine you have a kid who is trying to run into cars and you cannot for a second take your eyes off of that kid, and most people don't diagnose ADHD until age 6 or 7, imagine how long that is to feel like your child might self-destruct at any point. It's terrifying. Usually they end up getting advice from a lot of people that's like less sugar, fewer screens, and none of that stuff is bad. But imagine, what about the parent who they have a kid who likes to run into oncoming traffic and they need to make dinner for their family, and they go to a professional and the professional says, let's do fewer screens. That's why your child might be acting like this. And the parent thinks, the only time I can actually make dinner without my child potentially killing themselves is when I put YouTube on and sit them in front of a screen. That's an impossible position for that parent. What are they supposed to do? And then they go and they get the recommendation, make sure to feed your kid less sugar and do fewer screens. All the preventative stuff like that we learn about in medicine, it is important. I'm not trying to knock it. But this specific subset of kids, you're not going to be helping by saying those things. So that's why it's helpful to know what this subset looks like. They even did a study. They found that the majority of pediatricians, and it says pediatricians, but really it could be any professional who works with kids, I think probably would apply for this study. The majority of time, parents don't get told evidence-based things. It's not like if they come in with strep throat and we know how to treat them. They get told things by professionals like, do less sugar. And can you imagine if you have a child who's running through oncoming traffic, less sugar may feel a little bit invalidating. So, and I'm going to skip over these, but basically, it's a really hard thing for these parents. Now, they showed that in studies, bad parenting or parenting does not cause ADHD. So if you think that, whether you say it or not, I would kindly ask that you don't think that. So you can see here in this article, by preschool, parenting style does not create ADHD. Difficult behaviors from the ADHD child elicit negative interactions from parents. That goes with teachers, whatever. You find yourself yelling at this child all the time, the child is probably difficult. Not saying it's right, but that's what happens. Yes, how we change our parenting can be a modifiable factor. It can make a difference, but it did not cause the ADHD. And I put this example on a previous slide, but imagine you have a 4-year-old who is lactose intolerant. Should we change our practices and feed that child fewer foods with lactose? Yes. That means changing what we do. Did a parent, the way that they talk to their child, cause lactose intolerance? Highly unlikely. It is the same thing with preschool ADHD. So I really don't think blaming parents, which some of us do subtly, some of us do without saying it, and the parents can feel it, it's not helpful. I also want you to think of it as like a vision impairment. So partially, I think that's true of all ADHD, but especially these young kids. because they only have so much frontal lobe they're working with. They can only do so much. We need to use tools to help them. Like if they already have severe symptoms by 3 or 4, blaming the parent and saying the kid needs to try harder or do stuff, excuse me, it's probably not going to fix the issue if I'm being totally honest. Yes, it can modify it. Yes, it can help. But same thing, if you see a 4-year-old who needs glasses, I'm not sure if any of us go, oh, that's because the parent yelled at their kid too much or was too harsh. No. Or let them watch too much TV. No, a little kid who needs glasses, we all go, okay, they need glasses. It is the same thing in this category. These are the severe cases that need evidence-based recommendations, evaluation, and treatment. So let's get into some of the developmental aspects. It is important as you evaluate these kids to know all the normal developmental stuff. It is helpful. Now, pediatricians have a leg up on the rest of us here because they know a lot of the medical things. Teachers and daycare workers have a leg up on us when they know what's normal for a class and what's not. So it's more of a gestalt of, well, that kid's trouble, and I know what I'm looking at. So, but it's important that we know all of it. Just because when you evaluate a kid in this age, you're not just looking at, is this ADHD or not? You're looking at, is speech getting in the way? Are physical things getting in the way? So you really do have to have a context and know your developmental stuff to truly evaluate accurately in this age group. You have to know what is normal for how a child talks, when they can sit and read, things like that. So I think a lot of people know this base stuff, at least from medical school. We have to memorize it. A lot of things people don't know are the social, emotional, and cognitive developmental aspects. I think a lot of us know, okay, this is when a kid's supposed to smile, but beyond that, we don't actually know a whole lot. And so I will get into some of those details that'll help you pick out these kids. The other thing too is, I will be honest, this is not a quick and dirty, easy evaluation in this age group. Those of you who are saying, how do we know a hyperactive kid from a kid with ADHD? There is not a simple, easy way to do it. That is not what this talk is about. I'm going to give you some clues, but it really takes truly a thorough evaluation. It has to be comprehensive. You have to check everything out. It takes time, and you have to be careful with how you look at stuff. So that is my 2 cents. You look for patterns. So with these kids, there's going to be more of a, are they struggling with certain things? Is there a pattern of what might be a problem underlying? And we'll get more into that. For this age group, one thing that does stand out, even though I say you have to know all the developmental stuff, you have to pay attention to impulsivity. So yes, they have shown that they did this study that I almost included on here, but I realized it was not going to help what I was saying, but 70% of preschool kids were identified as being hyperactive by people looking at them. And no, that didn't mean they all had ADHD. Little kids are hyperactive. And how we view hyperactivity varies person to person. Since I'm in my 30s, to me, everyone who stands up straight and has energy to talk feels hyperactive. But that might be different for other people. However, in this age group, what we're looking for, because this is one of the clearest problems, but this is also what leads to one of the reasons for treatment, is the impulsivity. When you see a kid who is not just hyperactive, like they get out of their seat. Okay, for a 10-year-old who's getting out of their seat all the time, that might be clear-cut ADHD. We don't care about the 4-year-old getting out of their seat because all 4-year-olds are likely to get out of their seat. We care about the 4-year-old that's jumping into the empty pool for fun while their parent is paying attention, and they're doing that kind of stuff over and over. It's the impulsivity that is not only almost pathognomonic for this condition, but it's also why we need to treat them. We need to keep them from killing themselves. And honestly, it really does increase mortality. I'll save you from reading all of this, but they have shown that there are significantly increased mortality rates. And can you imagine a 4-year-old who is running in front of cars, like the problems that might come with that? And that is why you may not be able to pick out every kid who has ADHD in this group, but when you see a kid who is consistently doing crazy things, the parent is providing adequate supervision, then you really need to think maybe this is ADHD and maybe it needs treatment because we need to keep this kid alive. When we start looking at patterns of what we see in these kids, gets to be a little bit more of the subtle stuff. Kids who have ADHD early on they end up having a lot of problems across the board. They have problems socially, emotionally, and they have problems with learning. They have developmental problems. So you can see here in this study that when they looked at school readiness for kindergarten, they found of the control group, only 13% of kids were not ready for kindergarten, which means a whopping 87% of kids just generally were ready for kindergarten. That's compared to the kids who had ADHD. 79% of them were not ready for kindergarten. I think a lot of times what makes this topic hard is it's not just the variability and developmental aspects, but I think a lot of times we want to give kids leeway and say everyone develops at their own pace. And that is true. I'm a fan of that. However, sometimes when we see that there are problems, we go, okay, maybe this kid doesn't have ADHD. I don't want to call it that because maybe they just have a speech delay. Maybe they had ear tubes, and that's what's getting in the way. But I want to challenge you to think about it the opposite way. Maybe if they have all those things, maybe there's a good chance they also have ADHD because ADHD is super comorbid with a lot of stuff. And the reason to think about it that way is because we don't want to miss it. So it's easy to watch some kids and go, they're going to meet their own timeline. What about the ones who are already behind by the time they get to kindergarten? Do we want to just let them get to their own timeline? Sometimes the answer is yes, it's worth it. But what about the ones we start making a pattern where we go, okay, they're struggling in preschool. The preschool maybe thinks they need to be held behind. They're not quite ready for kindergarten. They struggle with their social things at school. They can't sit still. They're doing impulsive stuff. You're starting to build a picture of why a child isn't doing well. It's coming down to that impulsivity getting in the way of things, right? And that's when you may think, oh, we might need to look at this more. Another thing I keep in mind when I'm doing an evaluation is the genetics of ADHD. So it's 70 to 80% heritable. It is just super genetic. So when I see a kid, again, and we're building on this presentation, I see a kid who's super impulsive a lot of the time. We're not talking a one-off. We're talking, this is the child you can't let out of your sight or they're going to do something crazy. They're impulsive. They struggle with friends. They don't quite understand. This might be the kid who wants to be social, but they're biting their friends. And then on top of it, they're having a hard time sitting and learning their letters because they just don't want to sit. They're having a hard time getting potty trained because they don't want to stop what they're doing. Then on top of it, it turns out one or two parents have ADHD. You should probably start thinking, okay, maybe we need to treat ADHD in this child, not just to keep them alive, but what are the chances they're going to have it? Pretty darn good. We might as well call it early and treat it, right? So this is something that I just mentioned before. ADHD, I think of it this way, it likes to be friends with other disorders. It is it's very generous with its time and love. Basically, ADHD is super comorbid with all things childhood, if I'm being honest. Name seizures, tics, developmental delays, learning disorders, whatever you want to add in there, ADHD loves to be friends with them. So when you see a kid who has one problem, there's a chance they have another problem just because of Bayesian priors or something. Each problem means there's more comorbidities. The multiple problems mean there are multiple potential comorbidities. So when we see a kid who has a lot of delays, who has autism, who has hearing problems because of ear tubes, it makes us more scared to go, well, I don't know if it's ADHD. It could be all this other stuff. Well, again, I challenge you to think about it. Well, then that kid is way more likely to have ADHD, if I'm being honest. So let's take a look. Look at this beautiful picture of who ADHD likes to be friends with, just about everyone. And these are just the psychiatric things, really. But it doesn't even get into seizure disorders, other things like that. So all the little kid stuff, it's really comorbid. Now it is really comorbid with ODD, oppositional defiant disorder. And I want you to think ADHD is actually, it's more common nowadays than just straight up ODD. ODD rarely runs by itself. It usually is friends with someone else as well. I can count on probably both hands the number of times I've seen a kid who only has ODD in preschool. If you see a kid who you think they definitely have ODD, I want you to think there's a way, 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 way good chance that they have ADHD. So if you're already willing to put an ODD diagnosis on a kid, you need to rule out ADHD. Just flat out. Because untreated ADHD very often leads to ODD. It can happen by itself, but kids who are getting super frustrated, who are getting negative interactions, they get angry and they get oppositional. So if we can treat ADHD, a lot of times we can help to prevent the progression to ODD or conduct disorder. Now, there's a difference too, because ADHD is highly treatable. It's an actionable item. ODD is much harder. With ADHD, we give kids a medication, and the way I think of it is, and we do parent training and everything, I think of it as we're giving them a fighting chance to choose what they want to do, what they want to say, how they want to act. It does not mean we're suddenly elevating them to like acting amazingly. It means it's the equivalent of giving a driver glasses. They can see what they're doing. What they do after that is their choice. Do they choose to yell at a friend? Do they choose to use, bad words? Or do they choose to sit and do their work? That's their choice after that. And if they're still choosing to do mean things, well, there's a good likelihood that that kid has ODD and ADHD. I would caution you, if you're going to put that ODD diagnosis, that you rule out ADHD or rule it in, and don't necessarily put ODD on top until the ADHD is treated. The vast majority of kids I see in the preschool period, I wait to really evaluate for ODD once we have evaluated and treated for ADHD. So that's my 2 cents with that. Now, again, you just have to pay attention to the developmental things, and that can make it more confusing. But that is also why the more developmental issues that are going on, if they're reading impaired, they're socially impaired. If you can, sometimes, yes, we don't want to call ADHD when it's not there and feel like we're over-treating. On the other hand, there is a risk of not treating earlier and those problems continuing. So if you think all of this adds up to there might be a good chance that kid has ADHD, it might be worthwhile just calling it and treating, even if you're not 100% sure. Because you can stop medications. You can take the diagnosis off, especially if you're the person following. I am not saying that every hyperactive child you should go, well, let's see if a stimulant works. No. But if you're like, you know what, this kid is struggling in so many ways, and it could be ADHD, but it could be maybe a learning disorder, maybe a cognitive thing, it might be worthwhile treating them to potentially prevent this stuff. So, now, I already mentioned this, knowing all the developmental milestones are going to help you with that. So what do we expect? We expect these are developmentally appropriate milestones for attention. This is when we're evaluating, we want to look at this kind of thing. This is what I mean by it helps to know some of the more specific things that we don't learn in med school or therapy school. I don't know what I should call it. But you can see here, the attention span of kids, we're not expecting them to sit down and read the whole Bible at once or whatever. That would not be normal. However, we do expect, if we're looking at, you see 3 to 5-year-olds, we expect them to be able to sit and do something for a little bit. Now, this does not mean screens, because every child, no matter their age or attention level, can look at a screen for 3 hours. But it's other stuff. And it doesn't mean all the time. It means that there's some, and it doesn't mean necessarily non-preferred tasks. It means that this kid, every once in a while, can stop and do something for, if it's a 4-year-old, for 8 minutes. They can play with their toy cars. They can, play a game for a little bit. When you see a 4-year-old that quite literally does not have an attention span past 1 or 2 minutes, even for things they like, that is outside the normal range. And I don't just mean like listening to yes, I do think parent report is helpful, but even in your waiting room, you should have more than a couple of 6-minute time spans, I guess. If you have a 15-minute appointment, either to watch what this kid is doing and say like, okay, if you give them some crayons and they like to draw, how long can they sit there and draw for? And if it's not longer than a minute before they are acting out, you might want to consider that as a child who has abnormal attention at that age. Some typical executive functioning, these are some executive functioning milestones for this age group, is, okay, and I do have to explain each of these because I know we could all mean different things, but they should be able to resist some impulses, resist some distractions, follow 2 to 4 step simple tasks. Simple tasks. A simple task for a 4-year-old is not go do the laundry. For me, it should be a simple task. It isn't, but that's different. So I'll get into that. And then demonstrate knowledge of rules. Now, notice that says knowledge of rules, not following rules. Okay, that's different. So resist some impulses. What I want you to do when you are trying to figure out what's normal versus not for a preschool period, imagine you're at a kid's birthday party and there is a cake, big, beautiful cake, Paw Patrol, whatever, make it enjoyable. And there's a baby on the table next to the cake, and there is a 4-year-old equidistant standing away from the cake. This is a weird example, I apologize, but this is how I think of it. And you let them both have a couple of minutes. Within a couple of minutes, there's a good chance that baby will have crawled over, a 9-month-old and just put their hand in the cake. There is not impulse control in a 9-month-old. They're just gonna, you should know if you're gonna put a baby down next to something that looks fun, they're gonna go play with it, right? They're not gonna stop and go, maybe I shouldn't do that to the child whose party this is, right? No, they go straight to it. That 4-year-old should be able to, they see the cake and then they go, cake, Paw Patrol. They run to the cake, they point to it, they look at you and they go, whose cake is this? And you say, clearly it's the child's party we're at. And then they go, I want some. And they go to touch it and you say, no. That seems impulsive, but that's normal for a 4-year-old. All those little extra steps led up to, that was way more resisting impulses than the baby who just went bonk. And that's what we're looking for. It's that little amount of impulsive. If you have a kid that then just goes up and puts their face in the cake, you should think that they have impulsive problems, right? Same thing with the distractions. Yes, of course, if there's loud music playing, a kid might not be able to concentrate on what they're doing. But if it's raining outside, maybe there's a baby that's upset down the hall, most kids can just keep coloring. So we expect them to be able to stop, not every 4 seconds, oh, look at this. 2 to 4 simple tasks for a 4-year-old would be go get your shoes and bring them back. So it's 2-3 steps. A kid should be able to do that. If they cannot do that, every time you say it, you have to tell them 10,000 times to go get their shoes, and then they forget what they're doing, and they lose their shoes, and then they go watch the Paw Patrol. Apparently I'm on Paw Patrol today. I swear I'm not getting paid by them, clearly. It's just traumatizing to me with my own children watching it. But they should be able to go, bring them back, and that's that. It doesn't mean that every single time they will do exactly what you ask of them, but it means the majority of the time they can do the basic stuff. Go throw that out in the trash. They may not want to, but they will. Demonstrate knowledge of rules. Now, the preschool period are our little rule dictators. And it's funny because they're rule dictators, but only for other kids. So if they break the rules, they don't care. But it's when they see their friend breaking the rules, they're going to come tell you. Especially when they didn't. So they didn't go grab something, but their friend did. They go, oh, look, they did that. They shouldn't have done that. They're starting to learn the rules and they're excited about it and they want to get other kids in trouble. This is the tattletale stage. They should be able to know what the rules are. A 4-year-old at a birthday party who immediately runs up to the cake, starts digging into it, putting their face into it, maybe they know the rules, maybe they don't. That's a crossing that line that, they don't know. So anyway, so what's out of the norm? We just kind of went over it. This is a real picture from an article. So you can see here a kid on the roof. Yes, if there are supervision issues and a kid's doing crazy stuff because there's no one watching them because of pure neglect or something, we shouldn't necessarily jump to ADHD. But I will tell you that is the exception and not the rule. The vast majority of kids I see who end up having preschool ADHD are getting very adequate supervision, and they have extremely stressed out parents because they turn around and their kid does something like this, walks on the roof. This is not normal. A kid who does little slightly dangerous things, who jumps off the couch, they should know not to walk on the roof and that they might fall. This is abnormal. And I don't mean their friend talks them into something once. I mean, the ADHD kids are doing this stuff all the time. So ultimately, and I realize, again, I'm not giving you real strict criteria because it isn't there. And you don't have to call every young kid with ADHD, but it does help to know what these outliers look like because you can get them treatment earlier. So you have to know the most severe ones. It means ultimately, if you're going to call it, at least pick the ones who could potentially seriously injure themselves or someone else if we don't do something. So, and again, I basically sort of talked about all this stuff already. It can impact other aspects of development. So not only are they maybe hurting themselves, but they are not getting potty trained. They're not learning how to read because they have a hard time sitting down. So one thing that I think is really interesting now, let's get more into looking at more mild, moderate symptoms. So you can have mild, moderate ADHD in this age range, but It's a little bit harder to make, so that's why I didn't super focus on it. You want to pick out the most severe ones because those are the ones that are going to get the most help. But things that'll just help you in general know about evaluating for kids is there's something here that I love. It's called the maturational lag model. I put the video up on here. It's really cool. It was an NIH funded study. They looked at the brains of kids with ADHD versus not having ADHD and how they grew over time. And they found just really consistently kids, and this is not regardless of their age, kids with ADHD are 2 to 3 years younger emotionally because of frontal lobe development. The majority of them do catch up in their late teens, early 20s. They go through a growth spurt, just like a height growth spurt. They go through a brain growth spurt, which is really cool. But up until that point, they're 2 to 3 years younger emotionally. And I think this really correlates to what I see clinically. So when we see a kid who's 17 and they're acting like a 14-year-old, that's like a difference, but it's not huge. Think about the 5-year-old who's acting like a 2-year-old. And this is what we're going to see for the preschool age period. This is the complaint that you're going to get from the parents. I would say that's what I get 9 times out of 10. Not only are they doing impulsive things, but they're having temper tantrums like a 2-year-old because of this reason. They, instead of moving out of the 2-year-old period, they're moving into it emotionally. So we are going to see temper tantrums. We're going to see immaturity where they act like 2 and 3-year-olds at age 5. So keep that in mind. That is almost, I have to say, 99% of kids that I see correlates that way. The other thing too that makes it stand out is that a lot of us know now that older kids can hyperfocus. So it's an inability to control focus. So they can hyperfocus on what they like and they struggle to focus on what they don't like. Little kids have not developed enough frontal lobe and executive functioning that they can hyperfocus. I feel bad for these kids because they can't even focus on what they like to do. So they'll say, I really want to do this. Then they start doing it for a minute and then they get angry and they throw the Legos and then they move to the next thing. They literally don't even get the enjoyable aspect of ADHD. They don't even hyperfocus. So when you see a kid who can't even enjoy themselves because they can't focus, that should clue you in that there might be ADHD going on. So what's interesting is they are also pretty dramatic. We get the terrible twos because of their emotional lag. And this is something I could have talked about in the beginning, but they think one of the leading theories of ADHD is that it's an adrenaline deficiency. And what do we do when we have a deficiency? We crave what we don't have. So it's a norepinephrine and dopamine deficiency. So if you think about someone who's really thirsty, and what do? They crave water. You think about someone who is has low blood sugar and they're craving snacks. They're craving sugar. That's what's happening to these kids who have low adrenaline is their body is inadvertently trying to make adrenaline. They are stirring up drama. And when you ask why, 9 times out of 10, they're going to say they don't know. This is their body controlling them to try and get what it needs. I'm not saying it's right or wrong, like we should let them do everything, but that is they're trying to do what they need. So they are provoking, they are being impulsive. I just literally right before this appointment, I spoke with this great mom of a kid who has preschool ADHD. And this kid does things like say, can I have 15 scoops of ice cream? When she knows that her mom isn't going to. And it's that little thing, it pokes, right? These are the provocateurs, they poke because it increases that adrenaline. So then when we add it all up, what does it look like? We get, what does preschool ADHD look like? The severe kind. Impulsive kids doing crazy things, stirring up drama, provoking other kids, provoking people, not knowing why, doing it and then feeling bad because they don't know why, acting like they're in their terrible twos and being immature, maybe falling behind emotionally, socially, maybe with other aspects. Maybe they have a parent who has ADHD. All of that is like just picture perfect preschool ADHD. So you're thinking, okay, maybe it's ADHD. What do I do next? Get rating skills. And these are free rating skills. It's called the preschool ADHD scale. It's like the Vanderbilt, but preschool version. Vanderbilts are technically normed for 6 and above. So I found it, I like to do this. If a kid's 5 and above, I often will still do Vanderbilts just because it's easier because we have them. But below that, this is a more appropriate test, and it's free, it's online. I tell parents if they're wondering if their kid has preschool ADHD, I tell parents, like, hey, why don't you get the teacher or a friend or someone to fill this out? Just because you'll get a sense for, is it normal or not if you're not sure. And again, like everything in psychiatry, a lot of it comes down to context. Since there's so much of a range in this period for just general things, you'll get and you can have a daycare teacher fill this out. It doesn't just have to be a preschool teacher. It can be the person who does speech with them, whatever. They get to see them work. Um, what happens when you get a teacher who has her own kids who have horrible ADHD, and to her, she's going to write 0 on everything compared to her own experience because she is like minimizing because her like norm is off. What about the teacher that is burned out and every time a child speaks out of turn, they think that that's horrible? And I see both of these things, they happen. So we get these scores, but we still have to talk to people about it. Very often, if I get scores that don't quite make sense to me or don't correlate to what I see or what the parent sees, is I ask the parent, like, what do you think is going on? And there's usually a reason. Oh, well, they just started this school a week ago and we had to get these scales. Okay, maybe they don't know. So what you have to do is you really do have to take into account some developmental aspects. So I like this article, actually. I think it's really good. Is this ADHD or immaturity? And you do have to think about things like kids in the same class. There's such a big range between 3 and 6. Like a kid can be potty trained at 1 or potty trained at 4, and to some degree, it's all normal. So there really is a big range. You have to keep in mind things like, is this kid younger than the average age in their class? Is this a preschool group and this kid's really young? Is it they do have a history of neglect and so didn't start any sort of academic stuff until later, whatever. So you do have to keep that stuff in mind. And the thing is, I know I'm adding all this stuff to say, okay, well, it might also be confusing. It is okay if you don't know. It's okay if you are going through all these things and you're like, this kid seems kind of ADHD, but I don't know, maybe they're just impulsive, or they did have ear tubes, and I don't know, we just went through the pandemic, that little thing. It is okay to hedge and call it subclinical ADHD. This is not an official category in the DSM, but it really has studies on it and has shown that this is sort of its own little category. What this means is when I see a kid like this, I put in my chart like subclinical ADHD, I want to consider it, but I don't want to call it right now. And that is okay. What's important is that you don't do early closure. I can't tell you how many parents I get who are like, yeah, no, the person ruled out ADHD when my kid was 4. You cannot rule out ADHD when a kid is 4. You can rule it in, but you literally can't rule it out. You can say this kid doesn't have it yet or doesn't have it right now, but there's no, and the thing is, it could be how the person says it. It could be how the parent interprets it. But I have had so many parents. I had one this week who come to me and they're like, yep, nope, they ruled out that it's ADHD. And I'm seeing the kid when they're 7. And I'm like, well, that doesn't mean that they don't have ADHD now. So it's important that whatever we convey, that parents know that, like, this is a possibility. It could be ADHD, but I don't see enough to call it. That is much different than going, nope, that's not it. You have a bad kid or something. So again, they have studies. They've shown that, like, and I put this in here. We have lots of other things that we do in medicine where we call things subclinical and they have like real outcomes. It's just like that. I talk to parents and I feel comfortable, instead of going, yes, it is, or no, it isn't. I go, I don't know, it might be, and we're going to watch for it. It doesn't mean that we just go, but we go, you know what? Let's see how things go the next 6 months. Let's see how they develop. It's worthwhile doing. So, okay. Now, something that should automatically make you wonder about diagnosis of ADHD is if the child has gotten kicked out of preschool or daycare. I can't tell you how many kids I see. That should be like a trigger to, or bells to go off to go, oh, this kid might have ADHD. I should evaluate. Of course, things happen. Daycare's closed. It doesn't mean that every child in it had ADHD, but more likely than not, the kid with preschool ADHD has either gotten kicked out or almost gotten kicked out. And I have seen kids who they've gotten kicked out of every single one in the town, and the parents finally get to me because they're at their last chance, or else the parent has to quit work to take care of their child. And that's tough. So definitely watch for if they've gotten kicked out of preschool or daycare. And it's been happening more often than it should because they try to stop this. This is something you can see here. I put this little article about Illinois schools. They're supposed to have put a stop to this, but no, even public schools, kids get kicked out of them, even if it's illegal. So treatment. And I'm going to spend the least amount of time on treatment, partially because I'm going to do a second part to this. But the treatment is actually pretty basic. And the reason we know to do treatment is from the PATS study. And going back to what was that PATS study? They looked at kids from 3 to 5.5. They had 300 patients, something like this. And they follow these kids. There have been so many studies on top of this. Like there's a 3-year-old follow-up or 3-year follow-up for the PATS study. There's so many articles. And they came out and they said, okay, yes, you can have ADHD in preschool. It is a valid diagnosis. The kids who have severe ADHD, we should definitely diagnose them and we should treat them. If they have mild to moderate symptoms, so they're kind of hyperactive, they're kind of impulsive, they're behind a little bit, they probably have ADHD. Those are the ones that get just parent training or behavioral training, usually with a parent component. The ones with severe, they actually benefit from methylphenidate, yes, starting at age 4, and also the parent aspect. So they say, and they looked at the safety and efficacy of methylphenidate, and they said, yeah, it's worth it. It's even for a 4-year-old. Now, and this is sort of what I just mentioned, but basically parent training for all of them, and then the severe ones get meds. And they found that most of the time, this is not getting to be a recommendation. Now, when we look at general recommendations, and I put a slide in here, but this would be a great thing to talk about for 45 minutes. How can we improve attention in this age? Just general recommendations. Now, if they have ADHD, again, that is trying to improve vision in a kid that needs glasses. We're already kind of past that point, and there's no one to blame. But let's say we're trying to help them. Attention, just like any other thing, is something that can grow and strengthen. So how do we do that? There are lots of things. I just put one little slide on it. We can help kids practice inhibitory control by taking turns back and forth. That actually helps them because they don't get to immediately do what they want. So I say, my turn, your turn. Say your thought process out loud, especially when you're doing something with steps. And it can feel a little weird, but if you have a kid there at home or at school and you're going, okay, we need to pick stuff up. I need to put my stuff together. I'm going to do this first. That helps explain your thought process for kids who don't naturally have that organizational thought process. Increase routines and structures. It doesn't mean rules. It doesn't mean everything's a rule, but it means they have things that they can sort of put in their brain as a regular routine. And one thing that I do tell parents is, for a kid without ADHD, it might take them 1,000 times to hear something. For a kid with ADHD, it might take them 10,000 times to hear something. It doesn't mean that we just go, well, they didn't learn how to organize, so we're going to stop. I'm giving up. No, it means that they're going to need a lot more practice, unfortunately. So, and again, I put this note in here. It's okay when I'm talking to parents about this, I don't want them to get overwhelmed. The thing is, since it is so genetic, a lot of parents who have kids with ADHD, the parents have ADHD, and this is overwhelming for them. So I say, start with something small. Let's come up with a plan for picking up the markers. And when we look at stuff, which is the easier picture here for us to put the markers away? Now, the picture on the left, that's going to be pretty overwhelming for everyone. It's going to be hard to learn how to organize stuff when this is what you have to contend with, versus it's much easier saying, let's pick up the markers in the second page. And of course, this is a toy storage organizer picture, so this is not at all realistic. Probably the left side's a little bit more, but just having less stuff helps. So again, getting into the treatment, what all the guidelines say is that parent training, and that's not going to hurt. If a parent comes in and they're concerned about ADHD, you can navigate them to parent management stuff. And I always tell parents when there's parent management or PCIT or whatever, it doesn't mean that the parent's doing anything wrong. It means that they just need to learn how to change what they're doing to help their child who has these problems. So it is not putting a blame on the parent. It's saying, hey, you need to learn extra things because your kid has this problem, right? So and that's pretty much what all the guidelines say. So how do you seek out that training? Now, there are very specific programs, PCIT, parent management training, the Triple P program, and other things too. If you know of those in your area and you can point people to them, great. More often than not, they're not common, or they're not common. A lot of them we don't have around. It's just a service that we need more of. And if you don't know what's in the area, I recommend taking them to this website on the CDC. So the CDC has a ton of information on what kids who have ADHD, especially even preschool, what kind of parent management training they should get. So I say, go to this page on the CDC. Yeah, I don't know what services are around, or maybe I did, but that person left. We lost the service. There's a wait list for 6 months. They can go to the CDC website. And not only that, but they can, let's see, oh my gosh, I put too many words on these slides, didn't I? Tell them they can look at Psychology Today for local providers. And then the cool thing the CDC has is they actually, they go through what should parents look for. So they actually have, if let's say a parent's looking on Psychology Today and they're like, what kind of person do I find? The CDC website is cool. They say, these are the things that you should ask the therapist to see if they're a good fit. So you can see this on this left-hand corner, they have recommendations for that. So yes, I could go into all the services we have in the area. The hard thing though is that they either have long wait lists or we're missing people. And so I don't want to go into specific services today in case that's not applicable. Now, again, let's see, I don't want to go too much into medications, but just knowing medications, you don't have to get an EKG unless they have known heart problems, in which case, if you're not sure, get an EKG. If you do know, send them to cardiology. The most common things with the stimulants are lower appetite, sleep problems. And then, let's see, you want to always look for potential medical issues. So if they could potentially have low iron, they could potentially have sleep apnea. Those are all things that I will go into on my second part. When we're looking at medications, I'll look at other things like this that are medical, but you want to just keep them in mind. So ultimately, and here, those are resources, so Chad is good. This is pretty much the majority of my talk because a lot of these things are resources. So I want to say thank you. Also, if you do want to follow up with me, you can always contact Coffee. But one note that I want to make is that my university email I've had problems with. So either email me on my Carle email or email Coffee. And we're all done.
All right. Thank you, Dr. Johnson.
Yeah, let's see if I can stop sharing.
Yeah.
Okay.
Okay. And we've had a number of questions, so we'll go right into the Q&A. How does the ADHD diagnosis in the U.S. compare to diagnosis rates in other countries? If you have that information, that's pretty specific, but
no, it's a great question, okay. And we do have that information. I don't have, so the US, I think right now it's either the first or the second leading amounts of ADHD. I think last year India was first, interestingly. I can send that out if you want. They have found that it is a worldwide issue. So it is not just like, oh, it's only in the US. Yes, we do diagnose it more in the US, whether that's a US problem or whether it's accurate or it comes down to guidelines, I don't know. But the numbers are not super different. So even in the places who have the lowest ADHD, I think Africa was one of them or other places too. It's like 5% compared to 10%. So it is a worldwide disorder that is agreed upon as a worldwide disorder by experts. And the rate varies with the US in the lead, but other places in the lead as well. So yeah, that is one thing that there's more info on, but that's how I would sum it up.
Okay, thank you.
Mm-hmm.
With the family link, is it genetic or is it learned behavior from their grown-ups?
Tough question and a good question. I wouldn't say it's learned behavior. It is a predisposition. It is epigenetic. So the way I think of epigenetics is you have a light switch in a room and someone has to turn it on. So people can have the predisposition because they have parents who have it. And then yes, maybe it just turns on by itself because of biology. Maybe it's if you think about parents who have ADHD, they're going to have a hard time with organization, and that's going to make it hard for a kid who has a predisposition to a hard time with organization. So that kid may end up having those problems that they're going to have, but yes, the environment fed into it. There's some evidence that like trauma can potentially contribute to ADHD, because if you think about what if there's a lot of adrenaline for a child and then they grow up, they have an adrenaline deficiency because of that trauma they went through early on. All of this stuff can contribute to the development of ADHD, but usually there is a genetic predisposition. The other thing too is that they found that parents who have ADHD tend to have kids younger. So when you think about it, our populations are getting older and older having kids. So, if we have kids now, I don't know what, 35 or something, people who have ADHD, they're having kids still at like 25. What ends up happening is that you have more generations of ADHD people than of people without ADHD. So then it's spreading even faster. Basically, I wouldn't say it's created or learned or environmental. I would say it's a combination of a predisposition and genetics that gets potentially triggered by the environment, but not always. I know that's not a satisfying answer.
That's good. Thank you.
Yeah. Mhm.
Do these behaviors happen in all settings? What if it's just happening at home with parents?
2 out of 3. So it has to be at least 2 settings. For the criteria, you cannot only see it in 1 setting, it has to exist in 2. Now, 2 does not just mean home and school. Usually it does for kids, but it can mean out in the community in relationships. So it could mean the kid who goes to church or an activity and they're having those problems there. That can count as a setting. I would also say if it's only at home and not at school, you need to investigate more why that is. It does not mean blaming only home and saying school it's better. Sometimes we see extremely bright kids who can get by in school because they know the answers to everything. It doesn't mean that they don't have ADHD, but they can ace everything because they don't have homework. And then those are the kids, the bright ones, we often don't start seeing full criteria for ADHD until they get homework and it's really boring. So you have to keep in mind, why are we not seeing it in this other context, and why are we seeing it in this context?
Okay, thank you.
Mm-hmm.
Did you state the typical age of emotional growth, spurt, or catch up is teen years or young adult years?
It's late teens to early 20s. So like
Okay.
18 to 24.
Okay, thank you.
Mm-hmm.
And then this is kind of a scenario. We have a child that has started to show more extreme aggression, and he used to be redirectable, but there seems to be no redirection that works for him anymore. And he started to show more aggression at home, as well as he does have a lot of trauma in his background. And hearing some of this information, I'm wondering if ADHD is a potential. He often runs laps around the classroom when he should be sitting down for groups or lunch or breakfast, etc.
Yeah, go ahead and get that kid screened, I would say.
Okay.
So that's one of those kids where the aggression, if they're just kind of biting people, not to say biting is okay, but in the preschool age period, we see a lot more biting. If they really are going to biting, punching kids, they're flying through the room, and this is just like a nonstop thing, I think that would be like, yeah, it's worthwhile at least doing the preschool ADHD scales and just looking at a rating scale to see how they fall. But yeah, I would say that kid you're thinking the right direction.
Okay, great.
Yeah.
We have so many questions, but here's one that I think might be a good one. Just for a final question, is there a demographic that is diagnosed at an increased rate?
Oh God,
Or is that
boys. No,
okay?
so in this age group, so kids up till age 7, boys get diagnosed with ADHD 4 to 1, 4 times as much as girls. Now, girls become a lot more common to diagnose it, and it becomes like a 1 to 1 ratio in the later years, like after age 10, because most girls have inattentive ADHD. Now, there's debate on there. Is it that we're missing those girls and it's a diagnosis issue, or is it that their symptoms are truly not showing until later? Or is it true that just boys are more prone to hyperactivity? I don't know, but that is a debate. Now, they have broken it down in demographics. I think white kids are more likely to get diagnosed with black kids, but I think Hispanic are up there. I've seen varying numbers for that, so I can't speak to it, but there is a ethnic aspect that they have looked at, but I don't know, I don't remember what it is.
Okay.
Yeah.
All right. Well, thank you, Dr. Johnson. So I'll just do a couple of cover a couple of points before we close. The University of Iowa Carver College of Medicine is jointly accredited to provide continuing education for physicians, nurses, social workers, and then all other participants will receive a certificate of participation. Attendees are eligible to claim continuing education credit by completing the evaluation and downloading their certificate of participation. And I did put the instructions in the chat. However, I'll also send this in the follow-up email. And I did put my email in the chat if you have questions. So thank you, everyone. And I hope you join us for part 2 for medications in depth on Friday, April 19th. Thank you.